Hey, everybody. Welcome
Hey,
to
yeah.
another episode of Compliance Capers. I'm with my good friend, Betty Hovey. Here we are together
Hey, y'all.
again. Yay. All right. So, yes, our second episode, our second day of Compliance Capers. I'm so happy this arm has finally come to fruition, right? You and I have been talking about this. This has been in our playbook for quite some time. I know I've been alluding to it for quite some time, but we finally put forth 100% effort, and here we are. And we
Yes.
really do hope it is going to be a useful conversation. We really wanted it to be bite-sized, half an hour sessions to wrap up your work week, end cap it with a reminder for compliance, right? We really, again, don't want anybody to be caught up in these compliance capers, right? It's such an old-fashioned word, right? A caper. But really, it's about a, story gone sideways, right? We really don't want our practices, our beloved physicians and APPs to get caught up in these kinds of situations. And so, my good friend and I have been talking for quite some time about this concept, this storyline between us, that we really wanted to get something like this out to people in the industry, right? Because I think it's really going to hammer down the overarching point that we want to make with all of you is, stressing the importance of proactive compliance. We really want to get in front of things versus what we see in these capers, right? The OIG, the DOJ in particular, are great in their daily, weekly, monthly press releases that I know my good friend talks about in her weekly Friday fraudster posts. I talk about them at the end of each and every month on my Paint the Medical Picture podcast for the past 3 years. So again, we really, really believe that these types of capers are instrumental in the work that we do every single day in terms of we learn a lot from these press releases. There's a lot of fine details that are actually found in that paperwork that we can glean because we are certified professional coders, we're certified auditors, we're compliance professionals. So we understand the nuts and bolts of what these press releases are actually talking about from the various specialists that are hit and are in the news here in these types of compliance capers. So welcome back,
Gives
my
us
friend.
a lot of good educational points. That's what I think of. And yes, the name, it just kind of, we were playing around with names, and you're right. The capers thing, when we're saying it makes me think of, those old things that, yeah, it's a caper. See,
Exactly.
so,
That's right. That is right.
so yes, we're doing our best, doing our part to help practices to not end up, as I said last time, not end up being something that we're all talking about here. So we just want to make sure that we're giving everybody the tools necessary and the talking points necessary to take things back and discuss with your physicians, APPs, things that you can take back and say, oh, we really need to look at this now for us to make sure that we're not inadvertently doing something that's not correct and things like that. Because the ones that we pick out, of course, are the ones where there was just definitely something intentional, and they were trying to get away with something and got busted. But most of the practices that we work with have no clue that what's going on is not within the guidelines and within what is supposed to be being done. And so we point these things out, and a lot of times it's like, oh wow, I didn't know, and what do we do now? And when you're in the middle of having, records requested, you get those ADR requests from a payor or from Medicare or from, Cotivity, where, they're actually actively coming after something. It causes a lot of anxiety in a practice. It's very, it's very hard on everybody, and there's a lot of things then everybody's scrambling to get records and have the records looked at, and what should we have done, and you're trying to outthink or trying to put yourself in the state, what are they looking for, what did we do, and it can all be avoided, and that's one of the things that Sonal and I were looking at with doing this, is to help the practices to stop and think about these types of things before you get to that point where you're getting an ADR or you're getting a payor that's now asking you for a list of 150 different claims that you've submitted, and they want all the medical records, and it's going back for 3 years or more. I have one client that right now we're dealing with, and the claims go all the way back to 2017 that they're looking at. So it can get into, and the physician, she's just like, I'm not sleeping. I'm looking at all these things, and she's, I'm so anxious over all of this. And, it makes everybody nervous in the practice, and, it can all be avoided by, doing your own little checkups and making sure that, you're not falling into these kind of, bad habits and things like that can come back and really bite you. And when they bite you, it bites hard, because they're asking for a lot of money. I mean, think about that. 2017, almost 7 years ago, since we're getting into 2024 now, that's a big bite, even if it's a small service for the past 7 years that you've done it, it adds up real quick.
Wow. That's hefty. That's huge for 7 years. Yeah.
Yeah.
But what you were saying is absolutely true, right? The amount of stress that these types of additional documentation request letters put on a practice, put on a provider, right? They're sweating bullets, right, when they receive that piece of paper, because it's not in their wheelhouse. Let's remember that our providers are trained for 12 plus years of their amazing lives to be brilliant physicians, surgeons, whatever, specialists, right? That's their wheelhouse. They don't know what to do with that 7-page, piece of paper, all of those papers that come in the green envelope to their practice, requesting this, that, and the other, and some more in 45-day window. That's so quick. That's so hurried. They don't know what to do. They're scrambling, right? We can see them sweating. It's terrible.
Yeah.
So
and then
definitely try to avoid. We don't want them to be stressed out of their minds like that. It's uncomfortable. And I feel for them, because I've been through many a event like that over my years with practices that are involved in those additional documentation request letters, all the hoops that they have to jump through to make sure the payer receives everything on time, right? So then they're not docked some more if they miss the deadline. All of this is to avoid, any type of mayhem down the line. And as we said in our debut episode, proactive compliance really is key to help you avoid being on these hit lists that the OIG and the DOJ produce all the time, right? Our goal is, of course, and they too understand that people will make a mistake. They understand that the billing may go a little sideways from time to time. It's a mistake, right? But again, when Betty and I get involved, we like to remind practices that the payer is bigger. They have more tools in their toolbox. Everything is automated, right? So they can therefore look at all of your service lines over the past 7 years in Betty's example, right? They can do that at the push of a button, snap of a finger, whatever. It's that quick. And they can, outline it all for you, lickety split. It's so quick that they have access to. So it's that volume of error that they can then address, right? Not just that 1 month of something gone sideways. No, they're looking at 7 years of things gone sideways, right? And so when they put their lens on you like that, that's when they can use those terms of, fraud, waste, and abuse rather easily, because they're looking at the volume and not just the 1 month of something that went a little bit wonky.
Yeah. And as a side note, y'all, when you get those, don't call us when there's 2 days left.
Yeah, please don't.
That's the other thing.
Please don't. Because then we're sweating.
Make sure you press it right away. You should have a whole system set up that if you ever get this letter or this piece of paper, or you see that it's from this entity, it needs to get fast tracked to the proper people so that it can be taken care of right away. You want your stuff in early. You don't want it in at the last second, or you're calling and begging them to give you some more time because somebody buried it in a pile of mail and nobody looked at it. Now you have 2 days left to where it's due, and things like that. So make sure you have some protocol set up for when you do receive these types of correspondence in the mail. So that's another little tip there for you.
Exactly. Have the steps in place. Make sure your team knows what to do when they receive that in the mail, right? Someone should know what to do with it, not just file it away, squirrel it away in a desk drawer, take it home with her in her purse. No, right? Those types of correspondences from the government, from the SIU investigator at Anthem, all of those things should go to the provider, right? They should have their eyes on it first, and then the applicable team member who knows how to escalate the situation, right? Make sure you open the mail so you understand that it is something that requires an escalation because there is a deadline, right? 45 days. Or something to that effect. And we always advise that when you do receive pieces of paper in the mail like that, it's highly advisable that you, we know plenty, but contact a trusted and reputable healthcare attorney who can help you, calm the situation down, because they literally know how to talk to the government. They know how to talk to the commercial SIU. They know what to do, right? Whereas you yourself are not equipped to do that because you don't know all of the information like a trusted healthcare attorney does. So that's another great pro tip, is make sure that you have the right people on your team as well, who should come, like we said in last week's episode, you should have outside people advising you, right? Not just everybody in-house, but get external trusted advisors on your team to help guide you through these types of situations swiftly. Yeah. So now today's conversation of topic, I really wanted to talk about something that we've seen over the years a lot. But of course, there's been some recent cases towards the end of last year, right? 2023 in December. We did see quite a few cases come out relevant to upcoding E&M visits in particular. Now, this upcoding term, right, is kind of a Medicare CMS type of construct, this upcoding, right? So what does that mean, Betty, upcoding? Like to the general audience here that might be just now tuning in on a Friday morning. What is upcoding?
Well, when we look at it from what the payor is taking a stand on, is that from a documentation standpoint, let's say that your physician, your APP, is reporting a 99204, level 4, but when the documentation is looked at, it only supports a level 2, a level 3. So when the payors look at that and they come back and are having conversations with you, they will call that upcoding. You upcoded that visit. Now, we also see many times where I like to come back with my clients when I'm looking at their stuff, and you know that specialty, that it might not necessarily be upcoding, it might be under documenting. So that's
Nice.
one of the things to kind of keep in mind. They might have done that level 4, but the documentation doesn't stand up for that,
Mhm.
which is why we're going to sound like broken records with this stuff sometimes, but having
I
those
like it.
audits, taking a look at the records, because it's what's in the record that matters, not what was actually done for that data service, because the only thing everybody has to go by is that medical record. But when they're talking about upcoding, and in the case we're looking at, it blatantly is upcoding. I mean, there's not under documenting going on here, because that's just too much. But in a lot of cases, when they claim you're upcoding, it's really under documenting. So that's one of the things, for us to discuss as we, take a look at this case too, is to, make sure which one of those areas excuse me, you're falling into.
Yeah, that's a really, really great point, right? When we teach our providers, when we try and give them that extra guidance, you're absolutely right. We can identify where things have been underdocumented, right? They're just not, when we talk to them about, walk us through your day, right? I love to start conversations out
Yep.
like that. Walk me through your day, sir, ma'am, right? It's so much smoother because literally they chit chat away. They know exactly what they did with that patient on that day. They talk so freely about it, right? And then when they stop talking, I can interject and say, that's beautiful. That's all of the evidence I need to support a moderate level of service right here on 99214. Spot on, bang on, right? Right there in that eloquent, fact checking that they provided me for the problems addressed, for the data, for the risk. They do it all. They just help walk me through the day, but nothing was, matriculating down from the gray matter onto the EMR, right? That's what I
Yep.
always say. They do it. They did the service swimmingly. It's just not documented. It's still trapped up here, right?
Yep.
There was no time in their day, in their busy, busy day, seeing patients to type it all up in the EMR, right? But when you have a conversation with them, it's right there. And they do it so efficiently and brilliantly. I'm like, all of that just needs to be put into the EMR. So, yes, Betty, that's a great point where we are physician advocates and APP advocates for sure. And that's all we need is we just need to hear them talk. And literally the claim can be supported based on that conversation. But unfortunately, it can't, right? Because the payer won't reimburse you just on that conversation. It has to be documented in the medical record, right?
That's why I say, if you think it, ink it, right?
That's
If
right.
it's up here, it's got to get down there, or else
That's
we
right.
can't support it for you. And that's the biggest thing,
That's the biggest
is
thing.
that
Yeah.
support. But yeah, this case that you had found with this orthopod, it
Yes. Our
definitely
orthopedic
was
surgeon.
not.
Yeah.
It was this orthopod frequently billed for more than 60 patients per day, sometimes more than
Boy.
90 patients per day.
Boy.
Now, I hear a lot from my physicians and APPs that, boy, they want us to see 40 patients and 40, and they're talking about how little time that is in their day.
Mhm.
How
Yeah.
much they don't. And this one is 60 to 90 patients a day.
A day.
You know,
How?
um,
How?
so yeah, that one, again, this is an example where it truly appears, because I think this one is a yes, this one is an allegation at this point. So
Right.
Allegedly,
Allegedly.
Is a case where that just doesn't add up. And again, for over and over, for a period, when they look back at their records, they were looking at a period of 3 years. So for
Mhm.
those 3 years,
Okay.
consistently 60 to 90 patients a day,
Oh,
that's, not sustainable.
wow.
I mean, you could have a crazy
Mm.
thing where something nuts is going on, and there was some, natural disaster or something, to where they say, yeah, for like 2 weeks, they were working like a dog for almost 20 hours a day, blah, blah. Okay, that
Right.
you could, like, okay,
That I can
I could
understand.
see that. But
Right.
for 3 years,
Yeah.
yeah, that kind of
Yeah.
starts to get to where it
Wow.
doesn't pass the
Wow.
smell test,
Mhm.
so,
Mhm.
um,
Mhm.
when you were talking about this, Sonal, what the government did, which I thought was interesting too, to kind of point out,
Okay.
was that they were looking at the time then, because they
Ah.
said if they did that many, that would mean from the hours they were open, that this provider spent less than 5 minutes per patient if you averaged it out. And so when we looked at the codes they were reporting,
Mhm.
they focused on the times attached to the codes. So they
Of
said, in
course they
fact, it
did.
says
Wow.
they used billing codes that typically corresponded to visits of 15, 25, 30, or even 45 minutes.
Mhm.
So they took those average times in the E&M codes, and they used that to say, well, this isn't possible. Um, and that was one of the sides, that I said, well, um, time for me, at least, I think, is kind of a secondary way to do your
Yes.
E&M. Now,
Agreed.
depending on your specialty, I get that there are some specialties that say, no, we really, use that a
Mhm.
lot, and that's great if you do. But I
Mhm.
think for the most part, most of our physicians and APPs are reporting their E&M level off of MDM, now that we have the 2 ways only to do it. And
Yeah.
so it's very possible to do a moderately complex visit, a level
Mhm.
4, and not take the 30 minutes to do it. It doesn't take 30 minutes to do a level 4. You were pointing out, with the training and all the years
Mhm.
experience, that you
Yes.
can do a level 4 a lot faster.
Absolutely.
So I think they kind of
Mhm.
skewed a little bit, where there could have been some higher levels in there, but once again, over a period of 3 years,
Right.
consistently, that
Right.
overage, then it gets to the point of where you can't, how do you defend that? I mean, seriously,
Exactly.
you know?
Right. Exactly. Yeah. Such a great point on the fine details of this orthopod, right? Really great points. And hopefully, you guys can see in our conversation that the government really does, or did, take that time definition in our past E&M guidelines, right? In the definition of CPT from 1995 and 1997, they really pulled and honed in closely on those time increments, right? And then made their case based on those time, right? But as I've known, all of my providers over these years, providers in my own life, personally, friends, family, whoever, right? They are really smart people. And the way they think, the way they've been trained critically, their decision making power doesn't necessarily fit neatly into those little time increments that the AMA developed in CPT definition, right? They can do it a lot faster. But the greater point here is not just to applaud our physicians, it's to implore them to create better defendable documentation, right? So in the cases of these types of situations, these post-payment reviews, um, desk reviews, whatever you want to call them, um, once they start looking, they can start developing their own stories, right? Which they did in this orthopedic case. You don't want them to start their own story, right? You draft your own story of that patient and what you did for that patient on that date of encounter today. And make that story, be heard loud and clear. So there's no questioning and no other narrative that can intervene. So to your point, Betty, that's so true, that those time increments were kind of the devil of you, right? I mean, they really did pick at that time increment and put so many of that detail and language into these press releases over the years. I don't know what they're going to do now in the landscape that we're in, right? Based on the new guidelines in 2021, because we do still have that time threshold, a little bit different than what we were used to in 95 and 97, but there is still that time threshold in there at the end of CPT definition. So we don't know what they're going to do with that, right? But again, based on our experience, yes, you can definitely do things faster for medical decision-making purposes because you've been trained for all these umpteen years doing what you do best. So it won't take you whatever the time threshold is. You can do it under, right? And still qualify for that moderate level of service or even high level of service. But again, based on documentation, that has to be in there. So yeah, that's a really good point that I don't think a lot of people talk about. And I think it's important for our providers to realize that, all of their gray matter thinking has to really come down into paper, into the EMR. Yeah. It's no longer paper, but into the
EMR. And I would say, I don't know about you, but one tip that I give when I'm looking at records and doing audits too is that, they can take it or not take it, but if you're reporting your service by MDM, I always tell my clients, then don't put time in the record.
Yes, right.
Because if you're putting time, because I get that question a lot. Well, by time it's only a level 2, but by MDM it's so which one that you do it by whichever benefits you the most.
Beautiful.
But
Beautiful.
if you're doing this MDM things and you are doing them at a more rapid pace than what the time scale or threshold is in the code, don't put the time in there. Don't give something out there for a payor or somebody else to look at and kind of pick at you for and say, hey, this one's only this long and this one, that don't put the time on there. If you're billing by MDM, just bill by MDM. And I think that kind of can help make some of that, not be a point of contention, for maybe a payor to pick on.
Yes. Yes, really, really great pro tips there. Absolutely. And this is why you and I can't stress this enough, is that getting external consultants, external educators, external auditors on your teams quickly can really help you better understand, what it is you need to make sure that your service lines are being performed cleanly, right? And you're sending those claims out for reimbursement appropriately the first time. Remember at the beginning of our conversation today, we were talking about sweating. We don't want you to sweat, right? We want everything to be squeaky clean, sent out the first time. So when you are audited in the future, because you will be, everybody is going to be audited. It's just a matter of when it's going to happen, but will definitely happen. You don't have to sweat it out because you've had external professionals come in and teach you, help you, show you how to do things appropriately the first time. So you can, keep your reimbursement appropriately the first time and not be bamboozled with these extrapolations and later on and have that additional unnecessary stress, right? Because you're already stressed providing amazing patient care for your patients who are sick,
Yeah.
ill, they're dying from something. That in and of itself causes you stress when you go home at the end of the day, right? You don't need an additional stressor of this reimbursement green envelope that comes to you in the mail for Medicare or whoever, right? We're trying to help you avoid all of these additional risks that you really don't need to take on. You can avoid these compliance capers. That's again, the theme of our episodes here are compliance capers. We don't want you to join that club. Please
No.
join the compliance capers club.
And a lot of times it's just a tweak. It's not like everything has to be totally overhauled, or, you know, a lot of times somebody like Sonal and myself and other consultants, they can take a look at this stuff and say, well, you know, if you just do 1, 2, 3, you just do this one little thing or these two little things, then you're good to go. You know, it doesn't have to be, you know, that everything needs totally redone. Now, I'm not saying there may not be practices out there that really do need total overhauls, but a lot of times it's just something little. You know, like we were looking, we have a client that we're going through audit stuff, and I say, you know, if you just say that the images were external, the labs were external, you know, just that one word will fit to where if an auditor looks at it, they know, okay, but then I can give them credit for this. So a lot of times it's just little bitty things like that, to where if a payer does request records from you, you're not sweating it. You're like, okay, you know, let's copy them all up. Of course, you want to look at them first, make sure everything's in there. But then it's not like you're sitting there just sweating bullets for the month or 2 months it takes them to get back to you and tell you what they thought about them. You know, then it's more of like, okay, we know everything's, you know, we know we might have a mistake or two in there. Everybody does, but there's not going to be, you know, 80% fail rate on these things or whatever. You know, and that's kind of where you want to be, to where when you do get a request, because we keep saying you will, you know, when you do get a request, it's not going to be to where everything in the practice is in an uproar. It's like, okay, here it is. We have this many days. Let's get these records together. We're going to look at them, make sure everything's in there that we need to be in there, and then send them off, and then go about the business of helping your patients, and then just wait to hear back from them, because you're not going to think that some, you know, big bad thing is going to be coming down and, you know, the hammer's coming down on you.
Right. Exactly, Betty. Wow. So well said, as usual. Absolutely. Yeah. So, you know, this was our second episode of Compliance Capers. I hope everybody enjoyed all of our tidbits, pro tips, our nuggets of information. Again, based off of something that is publicly available, right? Those OIG press releases, DOJ press releases, everybody has access to them, but it's a matter of how you utilize them, right? So we implore you from this entire season that we're going to be with you, helping you gain proactive compliance. I really, really hope you guys stay tuned for our weekly episodes. I know we're really excited about it. We've been dreaming about this arm for so long, and we're happy that it's finally coming to fruition here. So, my friend, thank you so much for coming on again today on Compliance Capers. And you and I just have a great time, and can always have something meaningful to share with our audience. So I hope you guys have a lot of great takeaways from today's episode, and we can't wait to see you guys again next week. Thanks so much.
Thanks, y'all.